Good afternoon, everyone, and welcome to the VPS Spotlight series. This is Spotlight number 10, and today we have Conrad Krawiec from Penn State, Percy Children's Hospital, where he's an associate professor of pediatrics in Division of Pediatric Critical Care and the Department of Pediatrics there. He also currently serves as a pediatric intensive care unit internship director. He has over 50 published manuscripts and numerous abstracts and book chapters. And he currently is a peer journal reviewer for over 16 different journals. We only have about 30 minutes today as usual, so we are usually on a lightning track here. So without too much time spent, Dr. Krawiec is going to talk to you a bit about his publication that he did with his colleagues back in 2023 was in the American Journal of Perinatology. And the title of it was The Characteristics and Outcomes of Intrahospital Transfers from Neonatal Intensive Care Unit to Pediatric ICUs. So with that, I'd like for Dr. Krawiec to kind of take the floor here and get into his publication work. Conrad?
Thank you, Dr. Rice. Let me just share my screen. All right. Can you see that, Dr. Rice?
Yeah, it's coming through good.
Perfect. So before we begin, the only disclosure I have is that I received funding from a self-studier for his educational content, but it's not related to this research. And I also like to acknowledge my co-authors, particularly Dr. Lauren Mazur. She is a pediatric resident now at Boston, and she couldn't present this talk today because she's doing her first year of training. I'll also acknowledge one of our graduated fellows, Dr. Ahmed Beaton. Both Dr. Mazur and Dr. Beaton have been vital to the completion of this project. I also acknowledge my senior partners, Dr. Sinaviva and Dr. Thomas, and our statisticians, Dr. Pradhan and Dr. Zhu. All right, so some background on how we developed our hypothesis and a little bit about why we chose the approach that we did. As you all know, improvements in neonatal intensive care, as well as prenatal care, has resulted in an increased survival rate. A study from the United States National Institute of Child Health and Human Development reported an increase in survival with very low birth weight infants, a patient population known to have increased mortality, with improved survival from 74 to 84%. With this increased survival, there is also an observed increase in long-term comorbidities. This includes things like tracheostomy, long-term respiratory support, abdominal complications like necrotizing enterocolitis, development of nosocomial infections, intraventricular hemorrhage, and more. Because of this, survivors have an increased risk of mortality throughout childhood compared to other patient populations. Even though we know that these comorbidities occur and that they still have an increased risk of mortality upon discharge from the hospital, the key thing to remember is that they are surviving, and they are surviving to the point where they are transitioning out of the NICU. When I say NICU transition, what this most commonly means is discharge from the NICU. In other words, they get to go home. But transitioning from the NICU can have other meanings. Going home from the NICU is not the only possibility. They can have a short stay or a long stay in the NICU, where they can also transition home, or they can transition early because they are critically ill and need a life-saving operative procedure for critical conditions, particularly for things like congenital heart disease. And from there, they may recover in the PICU or the CICU, where they can go home. They can also have a long NICU stay, where they can also go home, but they can also wind up in the pediatric ward to feed and grow, for example, and then eventually go home. Or they may end up going to the PICU, where they need ongoing intensive care, from there they can go home. Or they can also be transferred to another hospital or be referred to long-term care facilities. The point of this slide is that NICU survivors may not only go home anymore, and they may be transitioned to somewhere else before they go home, to a place where a pediatric intensivist may take over their management. Anyone who practices or is trained in the PICU knows about these transitions, but there are some things we do not know. Which patients are being transferred to the PICU? How often does it happen? When it does occur, what are their outcomes? Have you ever accepted a patient from the NICU and wondered if they do better or worse? Have you ever accepted a patient from the NICU who experienced a bad outcome and wondered if there was something else that you could have done, or was there something that could have been done better? Or have you ever experienced having a patient and took maybe a different approach from the previous providers, and that resulted in a great outcome, and are thinking that maybe you're making a difference in this patient population? Well, if you ever had similar questions to ours, this is the study or the talk for you, as we attempted to answer some of these questions. So using the BPS database and leveraging the multi-center clinical data it provides, we sought to evaluate patient characteristics, age of NICU to PICU transition, length of stay, type of critical care support provided, and we evaluated the standardized mortality ratio. We opted to focus on respiratory and cardiovascular patients. As you know, NICU patients have a diverse amount of primary diagnosis, not all of which is seen in the PICU. Thus, we focus on these conditions because this is what we see as pediatric intensivists and most often manage on a daily basis. We hypothesized that the overall risk of mortality would be higher than expected for patients with respiratory or cardiovascular diagnoses that underwent a NICU to PICU transition. And we also hypothesized that specific factors are associated with a higher risk of mortality in the cardiovascular group. This was a retrospective study. We included only NICU to PICU transfers. We focused on the respiratory or cardiovascular primary diagnostic category. We also focused on ages 0 to 12 months, and we ensured that there were no age or weight flags. We collected clinical and demographic data, and our primary outcome was mortality. Characteristics and outcomes were compared by diagnostic category group using 2 sample tests or chi-square tests. We also did a multivariable regression controlling for demographic and clinical characteristics, such as age, sex, weight, PIM2 score, some critical care support like non-invasive ventilation, endotracheal tube intubation with mechanical ventilation, ECLS tracheostomy, and CPR requirements. And we also calculated the standardized mortality ratio for each group, which is the ratio of observed to predicted death, utilizing the PIM2 risk of mortality. And we considered an SMR greater than 1, greater than expected. We had initially found 5,852 patients, and when we applied exclusion criteria, we included 4,547 subjects. For demographics, the mean age and the length of stay was higher in the respiratory group. Mortality was similar between the two groups. To give us an idea of the type of critical illness that was transferred to the PICUs, we opted to describe some of the most common procedures provided. And we found that respiratory subjects had a significantly higher proportion of tracheostomies present pre-transfer and post-transfer. ECLS was present pre-transfer more often in the respiratory subjects, but more often in the cardiovascular subjects post-transfer. There was no difference in requirements. More cardiovascular subjects required intratracheal intubation and non-invasive ventilation post-transfer when compared to respiratory subjects. In regards to mortality, overall, the SMR was higher than expected. We looked at the different groups. The cardiovascular group had an SMR of 1.74, and respiratory was 2.07. In regards to clinical characteristics, the following factors were associated with mortality. Age, or the age of transfer, where the higher the age, the higher the odds of mortality. We also found that PIM2, pre-transfer endotracheal intubation, post-transfer endotracheal intubation were also associated with mortality. Reduced odds were observed in patients who were reported to have undergone tracheostomy post-transfer or required non-invasive ventilation post-transfer. So our conclusions were that, so we found that NICU to PICU observed deaths were higher than expected. I think it is important to know that the critical care support of various types are associated with increased mortality. But I also think it is more striking that the age of transfer for both the cardiovascular and respiratory group was associated with increased odds of mortality. And we feel that this study may warrant further study, particularly in regards to the timing of transfer. There are several limitations. It's retrospective, and we were unable to assess certain things like hospital policies or inter-unit communication. We also didn't know what the circumstances of the transfer were. Was this a planned transfer from, the NICU to the PICU? Or was this one of those urgent, middle of the night transfers when capacity was an issue and bed space would need to be free? We were also unable to assess a gestational age or the initial birth weight. We don't know what the cause of death was, and we don't know what level of NICU care was provided at these facilities. Thank you so much for allowing me to present my research. I'm open to any questions at this time.
Thank you, Dr. Krawiec. Let's see if we've got some questions coming up. In the meantime, I want to ask you, you said something about the plan of transfer, whether it was planned or whether it was more acute based on bed availability or urgency in the NICU. Did you, by any chance, utilize the scheduled or unscheduled checkboxes that is in the VPS admission criteria? Because usually that's, they're supposed to have a, quote, reservation within 12 hours to be a scheduled, or before 12 hours to be a scheduled. And I just wonder if that might have helped at least determine whether they were really planned or whether it was real acute. Obviously some of those patients have to be planned more than 12 hours, especially some of those little ones that are on ventilators with trachs and stuff. But what did you find, or did you look at that piece of the information that might have been available?
No, we didn't look at that piece, and I wish we had, because that would have been very useful. And now that I think about it, I super wish we had, because it would have been nice to see what the like for example, like mortality would have been between the two groups and stuff like that. Oh
yeah,
gosh, thank you for pointing that out.
Looks like we've got a couple of questions coming in. Let's see. Stephanie has asked, is it possible to look at transfers greater than 12 months? At our institution, it's not uncommon for NICU patients to transfer to the PICU after their first birthday.
That's interesting. That's interesting that you said that, Stephanie, because when I saw the greater than 12 months in the database, I thought that maybe perhaps it could have been an error, because in my experience, I've never experienced having a patient in the two hospitals that I have worked at being in a NICU for over 12 months. Is that a common thing? Is that a thing that happens in other institutions? Because if I had known that, I probably would have extended the age criteria. And so to answer your question, Stephanie, yes, it is possible to look at greater than 12 months, because we definitely saw it, but we just excluded them because we thought that maybe perhaps there was an error.
Okay. Nurse Lisa has a question. Did the events of multiples play a factor with higher mortality? For example, twins or quads?
So we had trouble identifying multiple gestations because I'm not sure it was reported like all the time. So we opted not to try to find those patients.
Okay.
But that's a very good point.
Chris has a question. Were you able to determine at what age of transfer mortality risk increased significantly? 9 months of age, 12 months, 24 months?
No, we didn't. No, we did not evaluate that, but it is possible to do so.
Stephanie, I think, was responding to the earlier question about 12 months of age. She says it is in Colorado.
I deeply apologize, Stephanie. I just made an assumption because I did look on various different publications to try to see if there was something that I could use to justify using greater than 12 months, but I couldn't find any. And I'm sorry, Stephanie. But now that I know, I will never make that assumption again.
Very good. Conrad, what's been the impact of the publication so far, and what further plans do you and your colleagues have for maybe going a little farther down the road with this topic?
So we don't have any future plans at this time, but it's something that our institution, I'm sure like many other institutions, maybe not necessarily based on this study, but maybe we are going sometime in the future to improve how we transition these patients from the NICU to the PICU, rather than waiting until there's a bed capacity issue or something like that. Maybe we should be more proactive and seeing if there's a certain patient that should be transitioned to the PICU sooner rather than later. That's something that's in the talks at this time.
Very good. We have any other questions from the audience out there? One other question I had while they're thinking of their questions is that one of your findings was that the time of transfer, the timing of transfer was significant, and how it was affecting the SMR. And I thought somewhere in there, I had the feeling you were suggesting that maybe we should think about looking at that as a qualifier or an addition to our SOI scores, or severity of illnesses. Have you thought any more about that? And if so, how would you think that we might be able to factor that in?
Oh, so when I commented on the age of transfer, I was thinking more about how maybe they're that in maybe in the NICU as they are when they have like an extended period of time where they have like a prolonged like hospital stay and such, that somehow it was impacting their severity of illness when they were finally, transferred to the PICU. And how is it impacting their severity of illness? I'm not sure. I'm sure there are many different factors that are involved. So I'm not saying, and so I don't mean to imply that being in the NICU is a bad thing. I think being in the NICU is a great thing. And I think being in the NICU, I mean, having a patient in the NICU with the survival rates and everything that they have is it's just it's a very good thing, But I think at a certain point, their age does, I think at a certain point, I think when they reach like a certain age where they are sort of like coming out of like the NICU period and stuff like that, I think we should be considering moving them earlier because there could be some kind of risk. And why do they have a risk? I'm not sure. Maybe they have a risk because they're in the hospital for a prolonged period of time because, they're developing like nosocomial infections or being set back by like sepsis and stuff like that. Maybe that's the issue. The other issue could be because, because they're older, we as PICU doctors, and I think NICU doctors think differently about how to like feed and grow patients in terms of like the nutritional support that they need and the critical care support that they need, In regards to maybe including it in regards to like maybe including it in the severity of illness, I'm not sure how that could be done. I'm not really familiar with that. But if I had to guess, yeah, maybe I'm not going to guess. I'm not sure.
Well, there are questions depending on PIM and PRISM that certain categories are excluded, but other questions that are answered, for instance, was this a trauma patient or was it a head trauma patient, qualifies for a difference in the score. And I think Gerardo is on, he's one of the statisticians or the head statistician for us in the VPS. Gerardo, I see you're on. You might want to send me a text or a comment on that. In the meantime, he's asked a question of you, Dr. Krawiec. He said, Gerardo asks, you mentioned scoring risk with the PIM models. Would you have expected big differences using NICU appropriate tools like SNAP, SNAP2, that?
I I think for if I had to guess, I would expect that if we use the NICU tools to try to determine the SMR and stuff like that, I believe it may not be higher than expected, because I think like we both have, like for the NICU and the PICU, we look at like different things. So maybe when the patient's admitted to the NICU initially, they may have an SMR that is appropriate. But because we were looking at transfer, I think that's where the differences came, you know. So to answer your question, no, I don't think there would have been a big difference upon admission, but I don't think those scores take into account the type of, like, how long they stay in the NICU, what type of critical care support that they provide during the duration of the NICU and stuff like that.
Question related to the actual transfers. Nurse Lisa is asking, did you look at whether the transfers were in-house or to another facility?
We focused on in-house.
Okay. And let's see. I see Chris has come back with another comment and a question. He says that in Colorado, we have devised a transition process to improve communication between NICU and PICU. Hopefully, we will have data to answer some of these questions, but as Stephanie mentioned, our NICU keeps patients till quite old ages and then transitions them to our non-ICU pulmonary service if they are trach and vent dependent, but no longer critically ill. Our current approach is to start conversations at 9 months of age with a goal transition at 12 months of age, if we assume the patient will still need an ICU at 12 months of age.
Well, that's great. I hope the scholarly product comes from that, and I look forward to reading that, because
I don't see any other questions coming up, so I can always keep more coming from me because I always have plenty of them. So I was just curious, the VPS data sets being used much more frequently these days, and a high percentage of the individuals who are using it are trainees in the various programs. And obviously some of this is time related, since it's already data that's collected and it's a fairly deep, and since it's all de-identified, they don't have to struggle with going through IRB to the extent we have on or used to. But with that in mind, how did you enlist your co-investigators? And I know there's a number of trainees on this call that are listening, and I think advice from a senior author sometimes is helpful about how you go about enlisting co-investigators for your project.
Gotcha. The way this project went down, I remember correctly. To be honest with you, when I first started using VPS in this multi-center fashion, I want to be honest, Dr. Neil Thomas made me do that, because I was focused more on single center, like when I learned about VPS, I was like, oh, we can answer so many questions here at Penn State or whatever. And then one time I had a question about about like obese patients and respiratory things. And Dr. Thomas was like, why don't you you're not going to have enough patients for this. I'm worried about you not going to have enough patients. Why don't you query from a multi-center standpoint? And so I was like, oh, I didn't realize that was a possibility. So I did that. I did the proposal. I did the IRB stuff and everything. And then after that, I was like that hooked me, because when I finally received the data set, it was just so much information. And I felt like, man, I can ask 100 different questions, though we focused on one question at that time. And then since then I was like, okay, anytime, I have a question, always think multi-center before single center and stuff like that. How did I convince my other co-authors to work with me on this? Well, Dr. Mazur was easy. Dr. Dr. Mazur is a very eager, physician. Was very involved in pediatrics and stuff like that all through her medical school career. I met her during her first year, and she is just like very like intense and stuff like that. So it wasn't easy to convince her. Dr. Beaton, also not hard to convince. He loves research, and he also had questions about like NICU to PICU transitions, because we had a couple of patients at our center that were transitioned in a very upfront manner, and he was very interested in it. In regards to like my division chief, Dr. Senaviva, he has just so much like experience and knowledge, and I think it wasn't easy to convince him to help, because he's been working for so long that he has an understanding of like the spectrum of the things that have been happening very early, like the changes that have been made early in his career to the changes that are happening now and that are ongoing and everything. So he wasn't very hard to convince. All I had to say was, "Hey, I'm doing a project on NICU to PICU transitions. Isn't that interesting?" And I only had one no, and that person I think just didn't have the time to help and stuff like that. But we already had a good, robust senior group from different areas and stuff like that to make this project happen. So my advice is have a very interesting, compelling question, be super excited about it, demonstrate that you can put in the work, and also don't be discouraged if you don't find what you expect to find. Never be discouraged, because any information that you uncover is still new information, and it's important to have.
Very good advice. I think that's probably why you're the director of the program there for the internship. One other thing, the Journal of Perinatology is not one that I usually peruse. And how did you determine that you were going to send it to the Journal of Perinatology rather than send it to one of the, like PCCM, Pediatric Critical Care Medicine? Because there obviously was some decision points in that process as you guys went through the project.
No, actually, we did submit to PCCM first. And they gave us some very good feedback, but they ultimately rejected the manuscript. And then I think they said something about like you should consider more like journals with like a neonatal for like neonatal care and stuff like that. And I was like, oh, that's a great idea. I didn't consider that. So then we submitted to the American Journal of Perinatology next, and they were interested. And they gave us good feedback from the review. They had like very robust feedback. But we were able to get it accepted. It was a lot of work, but it was certainly worth it.
Yes, I'm finding that it's a lot of work now that the journals are going to the online or electronic publication instead of the paper, getting a lot more technically particular about stuff, which adds more to the workload of the authors, in truth, because now we have to be aware of all their technical criteria. So I think you've made some very good points, and I really appreciate your taking the time out of your busy schedule to share with us your work, and hopefully our audience has enjoyed your presentation, and hope to hear from you again.
Thank you so much, Dr. Rice, and thank you for this opportunity. I really appreciate it.
You're very welcome. Thank you again for your time, and appreciate your participation in the BPS. With that, ends session 10 of the BPS Spotlight. Hope to see you again in November as we wind up the 2024 session. The speaker for the 20th of November is still to be a secret. How's that? So we hope to see you in November. Watch your newsletters. We'll send out the detailed more information shortly. So thank you again, Dr. Krawiec.